Hey guys, as promised, I said I was going to be recording chapter 37, chapter 38. So this hopefully will be quick. We've kind of discussed a little bit of transport operations, so it's nothing really extra to really hit upon. They're just going to kind of hit over a couple of key points. Try not to keep you guys too long on here. Try not to be too long-winded. It's just difficult sometimes, as you guys are aware, the way that they operate. So I do apologize, but without further ado, we're get started into it, okay? So we start talking about transportation and such. Um, we need to have an idea of what is in an ambulance. So we have basically what an ambulance is these days is a mobile intensive care unit, pretty much. So on four wheels, we can get you to and from places and maintain, hopefully, um, keep you hemodynamically stable or correct maybe some issues that are there. So it is remarkable how technology has come even for the short period of time I've been in this. So it's going to be really impressive to see where things go from here. So our ambulances today, as it says there, the NFPA 1917 standard of automotive ambulances. So those are designed based on that. So if you look into that, guys, it breaks it down as far as um, what compartments should hold what, the safety factors of it, such as the way that the box is built in the back. There are multiple belts. There's crush points in the sides, and the corners are basically indestructible. So heaven forbid that there's a rollover, we know that we're at least protected. First responder vehicles, they have all kinds of equipment that's provided there, and we are able to facilitate treatment while going down the road. So essentially, our point is that we are trying to get them to definitive care. That's the whole process behind it. So here's some components of the modern ambulance. So driver compartment, of course, that's where there's a typically just two seats. There's a driver and passenger. However, there are some extended cabs that can have more than a couple of seats in back. Those are typically for your long transports, is what we see. And there's a compartment enough back there where you're able to put two people supine. So you have your long bench, and then of course you have your stretcher. Those are your 2 points. You have your equipment, you have your supplies. You also have two-way radio. So there's one actually built into the ambulance, and then of course we have our walk-arounds there for those two. So these, of course, are not as have the ability to reach as well as one ambulance. The ambulances are amplified, so it gets out further. And of course, we try our best. It's built for safety mostly, but somewhat comfort. And you guys will see once you start doing your clinical ride-alongs, they're not as comfortable as they could be. So we know that it's mostly there to be safe and get people there. So what kind of chassis do we have here? So we have the Type 1, Type 2, Type 3. Type 1 is basically, you guys actually drove drove these, so you have a good sense of what it is. So a truck cab chassis. So the front of it is a truck, the back end of it is a box. The frame of it is basically a truck. Now the Type 2 is your van style. If you guys remember, that's what you guys drove when you was with me. If you happen to hop in that ambulance with me. And the Type 3 is kind of a blend between a van and a truck. So it has a heavy duty chassis, but with a van front end, if that makes sense. So here's we'll get to a picture in just a second. I'm sorry. There's pictures. I'm kind of getting ahead of myself. Um, so if you have the symbol on the side, the Star of Life, the Star of Life is a emblem that should be affixed on the sides, the rear, and sometimes on the roof to signify we are an ambulance. This is who we are. That each corner of those Star of Life, if you guys don't know, look it up. They're symbolic for different meanings and different reasons. So here we go. So this was the slide I was talking about. So your Type 1, Type 2, and then your Type 3. So Type 1 is the truck, right? So the Big Bertha is also still a Type 1, even though she's big. Um, You have your van chassis, as you can see there, and then of course, as I said, the blend between the two, which is your Type 3, which is a van cutaway, and it's in a box is integrated into it. And you'll see these when you guys do your clinical ride-alongs. There are Buncombe County has a hodgepodge mix between the two. So sometimes you might get an ambulance that has the van chassis, and sometimes it's a truck. And of course, when you go to the ER, you'll see all kinds of different kinds. So different phases of the call. So there are 9 different phases, and we'll go over each of those as we go along. The prep, the dispatch, en route, arrival scene, transfer of patient to the ambulance, en route, the receiving facility, which is your delivery, en route to the station, your post room. So preparation. This is what we should be doing every day as soon as we walk through the door. So if we have the convenience and the ability, we should be checking off our ambulance to make sure we have everything that we're supposed to have. Now, it can so happen, such as my day today. I came in and the crew was late coming back, and we were basically handed the keys to go to the next call. So we are kind of dependent upon them doing what they're supposed to do to be able to prepare us for the next call. Now, what you'll find is sometimes things are forgotten or things are not stocked solely because we're having to jump from one call to another. That happens. We just try to replenish the best we can as we go along. So, and of course, it depends on what agency you work for. Some things are stashed in different places than others. So it'd be very difficult for me to hop onto a Buncombe truck. I have a general sense of where their stuff is, but I would look kind of crazy trying to figure out where things are just because they are different than what we do. But however, most things are kind of set up the same. Typically, everybody has an oxygen. Um, some people have an oxygen saturation or an oxygen tank on the back of the stretcher. That's typical across the board. So administer oxygen rapidly. There are where they keep their oxygen supplies for their non-invasive stuff varies from place to place, but most things should be within reach, within a grasp as we're going down the road. So the cabinets, typically everywhere has a cabinet. Some places have drawers, but most places have cabinets, and they're labeled. Thank goodness. Ours are not labeled, but they are transparent. They are easy to see through. Therefore, you kind of have a good sense of what's in there. It's easy once you get affiliated to be able to know exactly where things are. Some other stuff that should be within hand's reach: airway ventilation equipment, your basic supplies, CPR equipment, and your basic wound care also. You have your splinting, your childbirth supplies, your AED should be within a good arm reach. All this stuff should be fairly accessible and easy to get to. Most of every ambulance, with the exception of say an AED, because we have cardiac monitors, they're normally there for you. Okay, and of course we have transfer equipment. That might be your stair chair, your stretcher. Also consider like your mega movers, all those different devices. We usually have a jump kit that's going to be one of those. Let's get them fixed right here so we can get them moved, just get them stabilized to where we can move them around. And of course, you have your medications. So outside compartments, typically we have our some extra PPE. So you might have a vest out there, gloves, a flashlight, all kinds of different stuff. Jumper cables. Most ambulances have jumper cables because the last thing you want to do is get stuck with a dead battery. So jumper cables to get you where you need to go. And pre-planning and navigation equipment. So most of every ambulance too also has some type of navigation equipment, and it varies between place to place. Buncombe utilizes a large CAD network system where they click on a button and they can navigate to the place. Ours is a little different. We have a lot of that information on our phone, so we can go in, type in, look at the map, know exactly where we're going. Some ambulances might be a dual fire ambulance, so they might have extrication equipment also on the ambulance. Minimal at best, but still they'll have some type of device there. So when we go through our prep phase, we need to have our personnel. There should be at least one EMT in the back of the patient compartment during transport. Once again, abandonment, right, guys? We can't leave the patient alone, so we have to have somebody back there. If it is a bad situation, it's better to have two people back there. Trust me, we stack two paramedics in the back of ambulances sometimes. That happens where it's a really bad situation, and we have to have two people. Likewise, EMTs. And you can have non-EMT drivers. We actually utilize a lot of the fire departments, and not every one of them are EMTs. So it works very, very well for us that we can just get somebody to drive us to the hospital, and we can have two paramedics in the back of the ambulance to be able to do the work. So. And daily inspections. So our checklists consist of, is there proper oil? Are the tires inflated? All those things are a daily check off for us. So we're expected to go through and check all those things off. It should be clean, especially in the middle of COVID. We should go through and spray everything down, make sure it's all sanitized and clean, and make sure everything, as I said before, is restocked and ready to go. And during this phase, of course, we can review precautions, make sure, we understand what the rules and regulations are, properly secure oxygen tanks, because those are very dangerous. They're very heavy. They can become a projectile missile if the end of it breaks off. So just know that it has to be secured very well. And likewise, all the stuff that's inside the cab should have some form of a restraint system to it. Our cardiac monitors latch into this grounded box, so it doesn't slide out and fly off and hit somebody in the head. So dispatch phase, just as much agencies, they are there 24/7, 365. They're always there to answer the call. Likewise, most ambulance companies are too. So there's needs and access. Of course, we know the number is 911. So these people call. First thing they ask, where is your emergency? So while they figure out where the emergency is, they can go and start typing their computer. And then once they ask them what the emergency is, then they can go ahead and start sending people where they need to go, whether it be fire, law enforcement, EMS, so on and so forth. So, like I said, our system, as Johnny had alluded to, it's called EOC, Madison EOC. There's some that's called the contact center. It just depends on where you work. So, what the dispatcher is going to gather is the nature of the call, the name, present location, a callback number, just in case they're disconnected, location of the patient. So they may not necessarily be there. We get what they call third-party callers all the time, where they say, "Oh, I'm just calling for my mom who lives in the next county over," and so they have to contact their 911. They have to be transferred to our 911. And then it's a big gone from there. But however, people do call for other people all the time, so they have to know where the patient is. How many patients are there, and what's the severity? Do we need additional resources? Something we always consider. And other pertinent information, especially these days, they have to ask, COVID. So do you have COVID-like symptoms? Please wear a mask when first responders come on scene. Very nice, nice for them to do that. While en route, this is the most dangerous part of while you're the whole call, basically, secondary to maybe transporting a patient to the hospital. This is where serious crashes can happen. And number one place is going to be at intersections, at three-ways or four-ways, or even just at a two-way road. It's dangerous. It's very, very dangerous. I would implore you guys that even if you have the green light, just take a light pause, look left, look right before you speed through, okay? Especially if you have a red light, please stop. Don't continue on. Just stop at that stoplight. You need to clear both sides, okay, before you move on. And if there's even a question, just stop, okay? I want you guys to be safe. There's too many injuries that happen while going to these calls, all right? We review our dispatch information, so the passenger is typically the one who's going to be running the call, so they can look at the information, get more information about the call. If we need to contact EOC, we can contact the call center and just say, hey, do you have even further information? And hopefully sometimes they'll give us more. And then we prepare to access and care for the patient. So during that time, guys, we should be kind of formulating, okay, they have chest pain. We should start saying, what medications can we give for chest pain? Oh, aspirin, nitro, allergic reaction, epinephrine, albuterol, Benadryl, all those things should be going through our heads as we're going, and just kind of rehashing up some of the things that may be deeply seated in the back of our mind. So once we get on scene, of course, first thing we do, scene size up, look around, look at a broad scope of things, look around. Is there any hazards? Is there any dangers? We should be able to look and see, do we have enough people? Do we need additional resources? This might include hazmat, your specialty units. This could even be fire, law enforcement, all kind, anything you may need. Okay, and we should be able to determine the mechanism of injury or the nature of illness between those two. So it doesn't the mechanism make you go holy crap? If it makes you go holy crap, then that's a severe mechanism of injury, guys. You should be like, we should probably get this person to the hospital quick, even though they may not show any signs of real bad issues. From there, of course, C-spine, right? So do they need to be fully immobilized, or do they just need a C-collar? We should assess that really quick. Standard precautions, as always, do your PPE, your body substance isolation, your BSI, whatever you need to do. Mass casualty incidents. So mass casualty incidents is when you're on one scene and you don't have enough resources. It has drained your resources dry. We have 3 ambulances in Madison County, and we can go to one accident that has 4 people injured, and that can take out every one of the ambulances if essentially one of those patients are completely unstable and need an ALS unit for each person. Completely possible, guys. With this, when you get on scene, don't be afraid to ask for more help, okay? If you think that the helicopter needs to come, like Johnny said, get on the radio and say, hey, we should get Mama coming if they're able to fly. All right, let's get them going. It's better for them to launch, be going your way, than to call them a few minutes later and think, maybe I should have called them earlier. If it comes to your head, you should probably act on it. Okay, guys? Incident command, your ICS, incident command system, should be established. That's going to be to the most senior person. So if you have a person that's been there for 50 years, knows what's going on, that's going to be your incident commander. Okay, that's going to be the person that tells you what to do. Safe parking, big deal, guys. Look at the slide, study it really good. Okay, so we should just know that this is some of the most dangerous times. Also, is to be on scene. You should wear high-vis jacket, something to signify that that you're a first responder, EMT, whatever have you, and keep an eye on your back and everybody else's. Okay, people are easily distracted and they will veer off and they will hit all these emergency vehicles, so it's very, very dangerous. So scene safety is the whole time, guys, not just for the moment. Okay, we should park 100 feet before or past, essentially past the crash scene. You do not park alongside the crash scene. Okay, that is dangerous, especially if you got traffic coming that direction. Very dangerous. So you need to go ahead or after. And these are all very dependent upon if you're the first on scene. We should always have a big old red ambulance or big old red fire truck behind us whenever possible. Okay, if they get hit, it's not going to do as much damage as if they hit our ambulance. So they'll usually turn it at an angle in relation to the roadway, and that way, if they do get hit, just the back end slides a little bit and it doesn't run into us. Always park upwind and uphill from hazardous materials. As you can imagine, things have a tendency to blow downhill or to blow across. So we don't need to have those fumes coming at us and possibly getting us sick. Always leave your warning lights on, even on a scene where there's people behind you. You still need to be seen. Okay. Blue lights get people's attention way better. Red lights, not as much. So we need to try to do our best to make those lights as bright as possible and let people know that we're there. And always keep a safe distance between all the emergency vehicles. Okay. So this is the best way. So you need a good egress. You need to be able to get out of there quick. So here you are, you have your truck turned sideways, the big old red fire truck turned sideways. There's the accident, and you are right there, ready to go at an angle to where you can just scoop up that patient and just get on out of there. That is perfect. That's where you need to be. Flares, we don't necessarily use flares, as Johnny said, because they can be dangerous, especially with spills. So typically you'll have cones is what a lot of people use. Once again, stay away from fires, downed wires, hazardous materials, and any unstable structures. So if a telephone pole is leaning over, stay away from that thing, okay? You don't want that thing to fall on you or electrocute you. Stay away. Set your parking brake just in case you do get hit. It's just secondary to the transmission being in park. So it helps to hopefully slow down anything that might hit you, all right? Facilitates your emergency medical care and rapid transport from the scene. And block the traffic. You need, and if you do have to block traffic, still work very, very safely, okay? Quickly and safely. Traffic control. We're typically, as EMTs, normally if we're providing medical care, this is not what our concern is. Our concern is in the patient's well-being. So this is crucial. Don't get me wrong. Traffic control is crucial to people. Let them slow down and let them know they need to move over, or if they need to come while another stop. It's all a big deal. Usually our fire departments are really good about that. They'll take care of all those situations. And warn drivers especially because people fly these days. They really do. So moving on to the transfer phase. So this is when we package the patient. I know it's a weird term, packaging. But you see how they're restraining this patient. They have that 4-point harness, and then they have the leg, and then the lower leg straps. This is basically packaging. You can also throw in scoop stretchers and long boards, wheeled ambulance stretcher. You know, all those are packaging devices. This will help you to lift the patient and put them into the compartment, be able to secure the patient, always using straps. So never let a person hang off of a board without securing them to the board, okay, or to the stretcher. It's very, very dangerous. All right, guys. So transport phase. So you inform dispatch of 3 different things: number of patients, the name of the receiving facility, and the beginning mileage of the ambulance. We don't do beginning mileage, however, but I think Buncombe does. They'll key up and let them know, hey, we're X mileage. So that's a give or take. We don't give information about the patient directly, like, you know, here's John Doe and his date of birth is blah, blah, blah. We don't do that, okay? Just those 3 things right there. We know this every 5 minutes for an unstable, 15 minutes for a stable. You guys got that one already. Contact a receiving facility. We need to give them a radio port. Say, hey, this is what we got. This is the age of the patient. This is what we got. This is the history they have, and this is what we did for them. This is how far we're away. I just still need to post that eye chart thing. I'll get that up to you guys. I'm so sorry. Hopefully, I'll put that up today, so that way you guys can see it. And no abandonment, right, guys? No abandonment. Stay away from that. We should always stay with the patient until someone of higher level care comes along. Delivery phase. So notify the hospital or dispatch when you arrive at the hospital. So Madison 5 has Madison 5 out at Mission Hospital. Done. We report to the triage nurse. So from there, they will send us to a certain room depending on the acuity of the patient. Then we actually physically transfer the patient. So moving them from the stretcher to the bed, having them stand, pivot, and sit, or just have them stand and just walk themselves. Or they can transfer themselves from the stretcher to the bed, whatever works best. We should have a complete detailed report, including some vitals, what was the last vitals, what did we do, all that stuff. So from there, we restock the used items, and then we're going to be back in service. So we inform dispatch whether we are in service or if you're out. So if we have used a lot of our supplies now, it seldom happens. We usually have doubles and triples of everything in the back of the ambulance. But you can be called out of service until you completely restock. So you may have to go back to the station, replenish everything, and then make them aware, hey, we're going to be back in service. Also consider your patients that you may have to clean or disinfect. Especially COVID, that does happen too, guys. Okay. So the post-run phase. So this is when we complete and file any additional written reports. There's not really written reports out there very much anymore, so we don't really see that as often, but they are out there. Do our inspection, refuel the vehicle, and then inform them of our dispatch of our status and our location, our availability. Okay, when we get into our post-run phase, guys, is when we clean, we disinfect, we do our high-level disinfection and sterilization. So after each call, we should be wiping down the stretcher. So you guys have fortunately been through, gone through your clinical ride-along, so you kind of see how we wipe down and clean everything down. Some people are better than others. Okay, I'll just throw that out there too. So I am a huge proponent of wiping it down after every single person. Some people are like, they wasn't that sick. Let's just throw some laundry over top of it and be done. Nah, man, I always wash it. Now, to any contamination should be used with soap and water, guys. We should be able to hose it down if we have to. Disinfect all non-disposable equipment. So think about your cardiac monitor, your SpO2 probe. If they have reusable blood pressure cuffs, all that should be wiped down really good. Germicide or bleach diluted bleach 1 to 100 is wonderful to kill most of everything. Okay, guys. The only thing that bleach doesn't kill is going to be C. diff, and that's soap and water. That has to be used soap and water. There are some germicidal stuff out there that will kill it, but typically soap and water works the best. Yeah, so there's typically some type of a schedule of routine to be able to clean everything up. There's typically policies that are written up depending on where you go to work to be able to take care of your equipment. Defensive driving. Okay. So if you don't already drive defensively, you should go ahead and start learning, because there are always a possibility that you can wreck an ambulance, and you don't want to be that person for one, but you don't want to injure yourself or the occupants in the ambulance too. Okay. So we need to have consideration for everybody around us at all times, especially when we are driving emergency. We should be driving with due regard to everyone else. Just because we get in that left lane with the lights and siren doesn't mean that we demand it, that it is that is our place. That just means that we are asking for people to move over to the right. So just keep that in mind, okay, guys, when we start talking about all this. Um, so driver characteristics, and I can tell you, I when I first started driving, I got a lot of speeding tickets. So the older that you get, typically you're less prone to drive like a maniac. Don't get me wrong, I still not the best driver in the world, I assure you. I try my best, but we all have our days. Today's been one of my days for me. As I said, due regard for other people and their safety, and preservation of property. Okay, so we're not going around, driving up and down people's yards and all that unless we absolutely have to. Okay. And as it says, speed does not save lives, good care does. All right. So you do not have to drive like Evel Knievel going down the road. It's all about keeping the person safe and just doing what you know to do, which is your ABCs and addressing life threats. Whenever possible, you should be wearing seatbelts, and that you should be restrained, especially if there's other occupants. They should always be wearing seatbelts and restraints. Be familiar with how the vehicle accelerates, corners, sways, and stops. Every vehicle is different, I assure you. You can have two identical year make models, and they might drive just a little bit different. That does happen, okay? And stay in extreme left-hand lane on multi-lane highways. So if you have more than 2 lanes, all the way to the left. Okay, people should know they should merge to the right. However, people don't always get that concept. Sometimes they want to merge to the left. They want to merge into the shoulder. They want to do all kinds of crazy stuff, but they should be merging to the right. So there is this analysis out there. It's the siren risk versus benefit. So this is still being looked at even today. This has been going on for quite a long time. And should we be responding with lights and sirens? Does that possibly pose a risk in hurting people around them, causing people to wreck? All those things we should definitely consider. And all these are drawn up with your medical director, the local protocols, your patient's condition, all these things will make you consider whether or not run lights and sirens, and everything changes depending on where you work at. So we should have an anticipation long before we get to we get to the driver in front of us. Are they going to brake? Is there cars in front of them? It's just probably what you do now. You anticipate what the person's going to do beside you, in front of you, behind you, and we should always have that safety cushion there. Okay, guys, we'll talk about that a little bit further on. Here we go. So these are things that you need to know. So maintain a safe distance from the vehicle in front of you. That also try to avoid people being tailgated behind you. I tell people all the time, listen, don't follow me. Okay, I am going emergency. You should be driving the speed limit. What do people do? On your tail the whole way to the hospital, lights and sirens. That's not safe. That is extremely dangerous for not only the ambulance who's driving it, but the people behind us. I mean, it's so dangerous. Be looking at your blind spots. So leaning forward, looking around. Blind spots are difficult, guys, but if we lean and kind of look in our mirrors, that changes our view and adjusts it to where we can see. Um, Never get out of the ambulance to confront a driver. Okay. No, yeah, we don't do that. That's not how we work. Okay. So, if you get mad at somebody, I'm sure you it happens all the time. Just kind of bite your tongue, and you'll probably forget about it in an hour or a day. So it'll be okay. So scanning your mirrors all the time, guys. So you should be bouncing left, right, and of course your rearview mirror doesn't really count, but just kind of looking left and right, and checking to make sure that no car or motorcycle or anything has come up on you. Excessive speed. So typically we don't go over 10 to 15 miles per hour over the speed limit. Some organizations have governors on their ambulances to keep them from going too fast. That is the thing, guys. So think about how much distance you have to stop whenever you're going excessively with a big old heavy ambulance, but also consider evasive maneuvers. So you go into an evasive maneuver to get around somebody, you could possibly start fishtailing and start breaking loose, and then you start rolling over the ambulance. That's a bad situation. And just know that this is going to hinder your reaction time too. It takes you that much more time to be able to counter for what may be happening. All right. The siren syndrome. Okay, this is a thing. So, especially we get sometimes some newbies driving an ambulance, never drove an ambulance before. They get excited, they hit the lights, they hit the sirens, and they start driving. And by the time it's all said and done, they're going 250 miles an hour. It does happen. So, what it is it causes the driver to drive faster in the presence of siren due to increased anxiety. So, they get anxious. They're like, man, I'm going to drive fast. I'm going to drive fast. It happens. It'll happen to us all. I assure you, it happened to me. Okay, it'll happen to all of us. Yeah, and once again, guys, so if ever there's any questions about your distance when you're backing up, just get your partner hop out and guide you and just kind of make you come back and tell them to stop, all those things, just so you don't run into stuff, okay? Especially when you're backing up. That's a dangerous time to run into people or into objects. It's very dangerous, okay? And we kind of talked about, you kind of felt this whenever you're driving it. Just know that when you hit the apex of a curve, depending on the chassis of the vehicle, you might if you turn into it, you might run over into the curve. So we want to kind of anticipate going into the curve kind of a little bit on the later side to be able to offset where those wheels are going to touch in regard to the center line. Okay, it is once again it's very dangerous to go into oncoming traffic, so be very conscientious
about how your vehicle turns. You should always kind of enter high into the lane and exit low is what it says there. I mean, this is pretty obvious, guys. Be careful driving, especially in water. An ambulance can still hydroplane. It's heavy, but it can still hydroplane, even at a low speed of 35 miles an hour. So be very, very, very safe whenever you're driving these things, okay? And laws and regulations. So, it is illegal to park and stand in a legal location, obviously, right? To proceed through a red light or stoplight without lights and sirens, to drive faster than the speed limit unless your local agency allows, to drive against slow traffic. That is negative. The only time that you should be allowed to do that is if they have the whole highway shut down. But you have to confirm that first before you start driving against the flow of traffic. That is extremely dangerous. And left to center is illegal as always, guys. So if you do have to go left to center, the only time that should be applicable is if you are having to get around traffic through a stoplight. But even then, you got to be very, very safe. And you got to make sure everybody's aware of what you're doing and be very, very careful doing that. Yeah, and we never, ever, ever, ever pass a stop school bus. No, it don't matter if it is the worst call in the whole world. We still stop. We don't want to hit any kids. So be so safe when you're around school buses, okay, guys? Um, Warning lights and sirens. So it must be a true emergency. So typically your dispatch is going to kind of let you know what it is. And if you use one, use the other. So if you use the lights, use the sirens. If you use sirens, use lights all the time. Got to use them simultaneously, okay, guys? We have the ability to shut off one and the other, but they should essentially be coming on at the same time. And once again, as I said, with regard to other safety and due regard to everybody else on the road. Yeah, um, so emergency vehicles have the right of way, but you're asking for permission. Okay, we shouldn't be endangering people or people's property. We should always be safe. Okay, when we talk about our right of way privilege. Typically, escorts are not really warranted. That's kind of dangerous situation. However, there could be situations where you are escorted. The times that I can think off the top of my head is if a law enforcement officer has been shot or injured. That is one of the times where typically law enforcement will escort you to the hospital. Um, that's about one. I mean, you can also be escorted if you're taking live organs, but that typically doesn't happen very often either. So just those are a couple ones that just popped in my head. As I said, intersections are very dangerous. I'm not going to hit on that anymore, but just know they're very, very, very dangerous. Okay, so be safe. And highways, of course, lights and sirens to the far left. Unpaved road, be very careful. We have a lot of those around here, so be very careful because it can get loose and you can get up in the ditch. So be very, very careful. School zones, we still need to obey the speeds. We need to go the speed limit through there. Don't be blasting through a school zone because you could essentially get a ticket. Minimize distractions. Don't be playing on your phone. Don't be using your radio. Don't be using GPS. You have a partner, use your partner. Okay. Eating and drinking you shouldn't be doing. It's dangerous. Once again, cell phones you shouldn't be using them if unless you absolutely have to. Finding a safe route and mentally preparing yourself, guys, that is the best thing to do. Our agency has a direct route in which we have to take. That they found is the most safest route for us to take to the hospital. So likewise, I'm sure you'll be informed whenever you start working at other agencies. Fatigue, you will get tired. Okay, it happens. If you work a 24-hour shift and you're up for all 24 hours, that is a bad day. So if you do get tired, if you got to, just ask your partner to see if they drive for a few minutes and then you take over after you take a quick nap, whatever. This is as long as you guys are safe. You got to do what you got to do. All right. We talked about this, guys, with Johnny. The biggest thing I want to talk about is the fixed wing units. So excuse me, we don't really have any around here. Typically, Charlotte, Raleigh, some of the bigger metropolitan areas, they have fixed wing units. And typically, what they utilize these for is to transport a patient from, say, the hospital to a higher level care hospital. So they go from Memorial Mission Hospital to, say, Duke or Emory or one of those higher level care, and for specialty services. Talked about the medevac. I'm not going to hit on that too much, guys, because Johnny done a really good job with his presentation. So, like I said, I could easily go onto this. So we kind of talked about this too, right? Advanced level care. If it takes too long to extricate, if they're going to be on the ground too long, if maybe the surfaces are not really good. You know, helicopters can land in some really weird spots, so they can get them out and they're straight as the crow flies, so they can get them there a lot quicker. Yeah, he talked about this, guys. Once again, I'm not going to go too deep into it. You can pause this right where it is if you want to look at this for just a minute. But as I said before, I'm not going to go too deep. Dispatcher, of course, uses people that can get the medevac system in route to you. So you should call them early if you anticipate it's a bad call. And whenever first units get on scene, hopefully they can elaborate on what's going on, and then you can be justified in launching the air. And as Johnny said, typically it is they're going to go ahead and launch, and it's going to they're going to just go ahead and launch, and then if they get canceled, they get canceled. They do the auto launch, so it's okay. 60 by 60, Johnny said 100 by 100. 100 and 100 is recommended. The bigger, the better. But 100 100 is perfect for a helicopter to land. If you can clear the loose debris, that's great. Just know the rotor wash will kick all that up, and don't be looking directly at it whenever it lands or takes off. It's dangerous, okay, guys? Don't use flares like Johnny said. Communicate about the direction of wind. Like I said, this is all stuff that he's already talked about. I'm not gonna beat on it too much. You should never approach the helicopter. However, if you do, you better approach it from the front. Make sure that the pilot sees you. Never approach it from the rear. That is extremely dangerous. As he said, that rear rotor will tear you up and there'll be nothing left of you. From the front, if you must. Typically, the flight crew is going to come out and greet you, so you don't have to actually go and greet them. They'll come to see you. So yeah, and you should approach crouched. However, what's great about the helicopters there at Mission is they're 10 foot off the ground, which is wonderful. But you should always kind of go in a duct. I don't trust it. It's so dangerous. So dangerous. Hand signals are not really used. If you can talk on a radio, like Johnny said, you're good to go. All right. All these things, once again, has already been told to you guys, so I'm not going to beat a dead horse. All right. There's hand signals if you want to know. There you go. We don't really use them much anymore, but there they are. They're good to know if by chance you work at an agency that utilizes these. And I'm sure there will be some type of training there. Remember what Johnny said about taking a cone, flipping it over, and putting a light in it? There you go. That's perfect. It works great. You can illuminate those cones on their side, and they're like, holy heck, look at that. It looks almost like a square runway. Let's land there. And of course, make sure you kind of know the terrain. They're going to try to land somewhere that is as flat as possible. However, we do live in hills, so approach from the low side and the downhill side of it if you do happen to approach the helicopter. But remember, always from the front when you can. All right. He talked about this again, guys. I know. I'm sorry. Like, this is what great about his stuff is he's already talked about a lot of this. All right. Yeah, and we talked about girth of the patient, so giving them an idea that they're X tall and weigh about X much, it helps the flight crew kind of have a good sense. Do I have enough fuel, and can they fit? It's good to know. We're done. All the following are examples of the standard patient transfer equipment except what? It is A, guys. There you go. All right. Jump kits. What is the purpose of a jump kit? There you go. It's a 5-minute kit. So that what you can kind of fix for them on scene and move them around. I didn't really mention the five-minute kit. Didn't really think about it, but that's what it is. All right. Tune into the next one, guys. I will have this one posted ready to go. All right. And we'll have a quiz, as I said before, just so you guys make sure you guys are paying attention. All right. Good job. Thank you.